Okay, we're live. We are privileged to have Andreas Horn here, who is, among other things, a clinician and an expert on connectomics in Berlin. Is that right, Andreas, where you're based? I know you spend
I'm in
some time
Boston.
in Boston. Boston now
Yeah,
you are at the moment, is that
yeah,
right? Okay, but your sort of your origin was in Berlin, was it?
yeah.
Great, and well, thank you very much for being here. We're looking forward to talking about connectomics and neuromodulation, in particular DBS, a prominent and well-proven form of neuromodulation. So, but perhaps you just kick off by telling us a little bit about your background and you ended up sort of in this area in particular.
Yeah, so thanks for inviting me. First of all, I studied medicine in southern Germany in Freiburg, and became interested in neuroimaging during my MD thesis there, and then went to Berlin to pursue that a bit further. Like essentially started with connectomics, so with using non-invasive methods like functional MRI, but also diffusion-based imaging-based tractography to study non-invasively the broader connections in the brain of living humans. And then was fortunate enough to be able to join Andrea Kuhn's group at the Charité in Berlin, where they also did deep brain simulation localizations. So already back then I thought it would be great to combine the two fields to some degree, and did focus some work on making precise reconstructions of where exactly the electrodes would line up in the brain with her, and then only once we had that settled, looked into what are they connected to, and that coincided with me going to for a postdoc to Boston to Harvard with Mike Fox, where we looked at essentially that right in a first paper, what differentiates the patients that would do great after surgery, have great motor improvement, for example, in Parkinson's disease, and their connections to which sites in the brain versus the ones that would unfortunately not do as great. And I went back to Berlin, founded my lab there 2018, and then now was recruited back as a faculty member here at the Brigham and Women's Hospital with Mike Fox in the center that he's leading. So the center is quite perfectly poised for that, or investigating that. So it is even called a Center for Circuit Brain Therapeutics. So essentially, with the aim of looking at which circuits do we need to modulate to derive good outcomes, or even extending that further, also which circuits would lead to side effects such as I don't know, depression in Parkinson's disease, or cognitive decline, or speech problems or so. So trying to see the world of neuromodulation in terms of networks, and then also using that to help patients in the long run.
Cool.
That's the
All right.
vision.
Well, let's back up a little bit and just talk a little some of the sort of basic terms here, because some people might not be that familiar with them. So what do we mean by connectomics? This is a term that I think was coined in like 2005 by Olaf Sporns, but what does it come to mean? Does it have several meanings, or what are we talking about?
Yes, great point. So because I think the connectome term is a great term, or was a great term from Olaf Sporns in 2005, and then now I think it's also a bit used as a hype thing. So essentially, we have to differentiate just brain connectivity, which goes back to at least 1920s of the Vogts in Germany, or whatever. Anatomists, of course, have always looked at networks, and people have treated Parkinson's disease, for example, as a network disorder since that time, right? Essentially since 1920 at least, or probably longer than that. So not at all new. So brain connectivity just meaning two things are connected in the brain, and maybe they form a network and a circuit, and really even back then people thought about modulating networks. So the connectome term is new and was originated in the imaging world, and essentially means that we break up the whole brain into parcels and then look at their interconnections. And often that's visualized by a graph, by a mathematical structure from graph theory, just nodes and edges across them. I think that probably so, and that has powerful consequences. You could look at specific properties of that graph, say how modular is it, or how each edge of it or each node of it, how central is it to the network? Is it a hub? Is it, and so on. So that's really the connectome versus connectivity being a much broader term, which just looks at brain connectivity. And I'd say that for most of what we do and most people do in the DBS field, currently it's more like connectivity DBS, so not connectome DBS. Although there have been people that looked at it in that connectome fashion, where you would look at really something like, how does the centrality of this node decline with DBS and so on. So that would be true connectomic DBS, let's say. I think personally, my lab is, looking a lot on connectivity, and there are some things that widely overlap with the connectome fields, which is in the imaging domain, where, for example, we sometimes look at similarities of whole brain connection profiles, which, could deserve this connectome term. But I think the more important thing really is what we're interested in is which connections, so connectivity, which connections are crucial for clinical outcomes.
Okay. Well, let's ask another basic question, which is like, why do we need to worry about this? I mean, we probably, most of us have seen the videos on YouTube. A patient has their DBS system switched off. They have terrible tremors. They switch it on, and abracadabra, they're much better and able to drink a glass of water. So why do we need connectomic as a dimension of DBS?
Absolutely, great question. So for me, there are two levels. We could look at the local level, where to stimulate, which coordinate, like which sweet spot we often call it, and which network. And you're right that we can explain a lot of variance just based on the local level, where we can say, hey, stimulating this spot is great. Why do we need connectomics? So a few reasons. One would be more from a basic science perspective. It's really helpful to know which networks are associated with that sweet spot, right? So just to learn, let's say, it's not really that we need to modulate the STN, but we also need to modulate its connection with premotor cortex. So that will help us better understand, let's say, Parkinson's disease or obsessive compulsive disorder as a disease. So we can essentially even use DBS, deep brain stimulation, to investigate the functional connectome of the brain, right, as a tool. Because if you have such a graph and you can modulate one node of it, you can see what happens in the network. That's really a powerful tool for basic science reasons. Now, for clinical reasons, I think there are also great examples where the connectomic part really shined. For example, we could show in obsessive compulsive disorder that that's a disease, right, from the neuropsychiatric domain, and there are different target sites that have been discussed which would need to be stimulated. One is the thalamic nucleus again, one is the anterior limb of the internal capsule. We could show that in both of these targets, the same tract that connected the two was important to modulate, right? We could even use connectomics to cross-predict across the two targets. So built a model of optimal connections just based on one target, one cohort operated with that one target, and then predict the ranks of the other arm, right, of the other target. So that way we could, that was maybe the best, so far, the best demonstration why connectivity could matter, because we could not only show this is the spot for one target, but we could show this would be the network, and maybe you can stimulate it at different sites.
But let me be a skeptic and say, well, what you're describing sounds like a result in which you demonstrated statistical significance. What would you say to the skeptic who said, we've yet to see evidence of clinical significance?
But I mean, it is, I don't know what you mean with clinical significance. So it was a retrospective study, that's true, but we did predict ranks in clinical outcomes, right? So it was not just that, the same tract is modulated, but we could show that it's crucial to modulate that tract in these patients we investigated.
Right, I see. So
we need prospective trials to validate that, and I totally agree.
I think you're inferring that I'm rather more sophisticated than I am. No, I was just trying to push on that question of, I guess it's a more general point that it really is true that we very frequently still see patients that have a poor outcome from DBS, right? In OCD, but in movement disorders as well. I mean, the guy that I mentioned on the YouTube videos, right? They never show the patient that had a bad response, right?
Yeah.
They always show the guy that had a miraculous, recovery of function.
That's a great point. Yeah. So my hope is that we can, so you're totally right. Maybe that is your last question. Some people already do great. Why do we even need to investigate it more? But so I think, maybe right now, probably in Parkinson's DBS, just gut feeling wise, 90% will respond, but only, let's say, 30% will be these excellent responders. And then my aim is to make that 30%, 90%, or try to, absolutely. And that could be done with connectomics, but also just with good imaging. So it's, both levels, the local one that's important, but then also the network level. And trying to get more deliberate and trying to, probably we won't be able to improve the 30% even further with what I'm doing, but we could make more people top responders, essentially. That's what
do you think clinically speaking, you think those 30% are getting as good a response as it's possible to get?
So I would think as good as possible with what we're currently doing with this classical 130 hertz always on DBS. I think to improve those further, we would need something new, disruptive, which could be adaptive DBS. So far that, it doesn't look like that either, that, patients would really get better than with continuous. So adaptive DBS would be that the system would listen to the brain and then only modulate based on specific rules that.
We've seen the now the release of the first commercial device, right? The Medtronic Percept system. So that's a reality now. But you're saying that we've yet to see real evidence that that's the game changer, or is going to be the game changer that we had hoped.
So even there, I would hypothesize it won't change these top responders even further in terms of their motor outcome, but it could maybe help reduce side effects, right? That the system isn't always on could mean that it's only on when really that effect is needed, but then it's often maybe not detrimental to some other function like speech or whatever, if it's adaptively off when not needed, essentially. So yeah, I think with the current technology we have, it will be hard to improve these ultimate top responders because they often already go down to nearly no symptoms anymore, right? For a while, and then Parkinson would progress further, unfortunately, and that is probably the nature of the disease. It's neurodegenerative, so we can't restore that with DBS at the moment.
Yeah. Okay, that's really interesting. There's another, I think, important distinction that we haven't really gone through, and that is the kind of, as I think you say in this very good review paper, opportunities of connectomic neuromodulation. And you mentioned a little bit in your sort of preamble. Actually, people have been thinking about networks for many decades, if not centuries. But what's really changed is our ability to characterize them. And you mentioned in that paper 2 main modalities. Now, I'll let you sort of explain. Is that right? Just functional and structural might be the.
Yeah. So now that there's video here, I can even show a book from 1950, and this is from Edward Creek now, and so this is actually from that time, and this is the connectivity of the brain, right? In colors, even with it's beautiful stuff. So it's really important to always highlight that brain connectivity is as old as neuroscience. So it's nothing new under the sun there. I think what we came up with, or people came up with in the last 2 decades would be non-invasive ways to characterize connectivity and in the living human brain. And that is very elegant from a physics perspective, but then also I would even say these old methods were much better, but they are limited to post-mortem or dead brains essentially, or animal studies and so on. So I think now we are at the situation where the ground truth is still in the anatomy books, definitely, and we have a means to derive some sort of personalized poor man's version of that anatomy textbook that fits our patient, and that's a great advantage, I think. And now the other thing with really connectomics, right, with the idea to parcellate the brain into like a whole brain connectivity profile, that is also new, and it might just be new because of the computational resources we have, right? Often that involves having, 20,000 voxels in the brain and having a 20,000 by 20,000 connectivity matrix. So that was just probably not feasible way before the 2005 Sporn's paper, at least not on a laptop, So it, I think that is probably just new because of that we have the computational resources to create connectivity profiles across each and every voxel in the brain. And I think you mentioned the two methods. So one is functional MRI, that is an indirect method of brain activity. Uses it's called the bold contrast, blood oxygenated level dependent contrast, and it essentially uses the fact that hemoglobin is slightly different. It's in terms of its magnetic properties, whether it's oxygenated or not. So it essentially uses brain brain oxygen and blood flow ratios to derive at which area is active in the brain. So if you have a human seeing something, a flicker board of light, then the V1 region, the primary visual cortex, will light up and will have more of that bold signal there. And then people have come up over the years with good resources looking at that. Now, resting state functional MRI would be to look at the co-fluctuations, right? If the two parts of the two motor cortices of mine would co-fluctuate and their signal would go up and down in the same way, they would be just correlated in time. And that would mean what we call functionally connected, right? It's very far from a real axonal type of connection. It is more a statistical rough guess that these regions do something together, but what they do together, we don't know, right? So the temporal resolution is also really slow in fMRI. So it all boils down to, it's a poor man's version of connectivity, but it works in living humans, which is amazing. And, we can use that to estimate things, right? So it's a very derived method. The same way derived is diffusion imaging, which measures water diffusion in the brain and has the aim to rather look at axons or like anatomical connections. Again, we won't see the axons. They are way too thin. We will see the very big highways in the brain, right? So state trooper highways that you have here in the US. Yeah. So that's what we see. And again, so there's, and again, so maybe just briefly explain that would measure that diffusion or exploit that diffusion would diffuse slightly more perpendicular to the axons rather than, in parallel to the axons rather than orthogonal to them, right? So it would exploit that fact, and based on that, there are algorithms, tons of algorithms to reconstruct the tracts. But yeah, it's an important point that especially if you just scan a single patient in a clinical setting and you derive their connectivity either with one of the two methods I outlined, it will be so coarse and poor resolved and so on that it's even a good question: does it really help us for deep brain stimulation? Because in deep brain stimulation, millimeters really matter. Being 2 millimeters off target might, result in only 30% improvement rather than 80% improvement, right? So it really matters. And with the two methods, we have trouble seeing these fine details. And we also have trouble fractography with the diffusion one to see the very thin bundles in the brain and so on. So my lab has focused a bit on, rather than using patient-specific data, to use big cohorts of brains, essentially, that were scanned, plus also histology data or, other types of like more textbook connectivity data, to infer with our patients. We know where the electrode is, we know where the structures are. That way we know what they are usually connected to, and we exploit that.
Yeah.
But we've done both. I mean, looked at patient-specific data, but also then more high-resolution atlas data.
And is it possible to combine the two forms of data in the same patient?
So I would love to do that. That's one of my focuses for the next years, to find good ways of merging information from a high resolution, even a post-mortem connectome that was scanned at the best center in the world, probably here in Boston, the Martino Center or so, with the patient-specific scans, and then individualize the high resolution data. So I think that's definitely a future topic that's fruitful. So then you have best of both worlds. You have patient-specific high-resolution connector somehow, but we're not there yet.
So it's sort of interesting. So with the structural connectivity, we get a kind of, like you said, a highly imperfect, but sort of, as it were, solid kind of direct measurement of the connection, albeit a giant highway. Whereas, but it doesn't really give us any kind of functional information about, that highway could actually have no cars on it, right? Nothing. Sure. It's possible that nothing's going up and down it.
Unlikely, but yeah, possible.
Yeah, I agree with you. Yeah, absolutely. But that's kind of, it gives us anatomical kind of a reconstruction rather than a functional reconstruction. Whereas with the fMRI, we've got these two areas, and we're looking at the bold signal. If they co-vary, then we can say there's a statistical relationship with them. That could be because there's a highway between the two, but it could be because there's another area that they're both connected to, or even some other, several removed. So that A and B are connected to C and D by each other, and then C and D are connected to E, and that's where that at least does give
maybe to jump on that, I'd even say that the word functional connectivity for fMRI is probably a misnomer.
Yeah.
And I see them more as co-activations, and I think that's the better term. They likely are in the same network if they're co-activated, but it doesn't really mean they have to be connected.
Aren't there other techniques, like, for example, if you're able to predict the behavior of one area from the behavior of another area immediately preceding it, it kind of maybe gives you a slightly stronger kind of
so the people have explored that, like Granger causality or dynamic causal modeling, which is a more complex model-based derivative to with a model inversion step, where you would solve these things on a neuronal code level. So essentially trying to, from the blood level, go back to the neuronal level, infer that, and then on that level create the graphs or the directionalities of the connection. And people have then termed that effective connectivity.
Yeah.
And I'd say for tasks, and especially the case of DCM, this has been worked out quite impressively and is really nice. I think just with the lag stuff, like Granger causality, where one signal slightly precedes the other one, I'm no expert in it, but I'm not convinced because the signal is so slow. And I've just heard experts actually in the last I think OHBM podcast that were also all not convinced by that. So I'm not alone in that. I think they're such a slow signal. So we're really thinking about each data point in an fMRI signal is usually 2 seconds from each other, right? So a curve would be 10 seconds at least, right? So and then measuring the lag between two of them will result in a lag of maybe a second or so, and that just isn't brain connectivity, right? So
you don't see any of these techniques like Granger causality or dynamic causal modeling. You don't see these things impacting clinical care in the near future.
So I think DCM more than, so I wouldn't lump them all together as one, but in DCM there's one really nice study published in Brain from the London group where they had deep brain simulation, like scans on and off deep brain simulation. I think it's quite old already, from probably 2012ish or so, 14 maybe. That where they then looked at DCM to look at which pathways of the indirect and hyperdirect pathway and so on would be modulated by deep brain simulation.
Right.
George Carhan is the first author, and I think Carl Fristen is on it as well. So it's a nice paper, and I think that type of analysis could help us, probably not clinically, but to understand what's happening in the brain. So I think they have, so the whole Fristen group with DCM, they have built such a vast body of evidence that this seems to be working if you really know what you're doing and so on. So I wouldn't say DCM is not useful, but
yeah, no, I wouldn't want to speak ill against the great Friston. Um, but
yeah.
But yeah, okay, that's cool. So how do you kind of, I mean, as you say in your paper as well, this it does seem like a very promising sort of plank for sort of in the overall sort of support for clinical care. What do you see, like, say 5-10 years down the line, if kind of we get your work in connectomics and other colleagues in connectomics works out? How do you see it kind of affecting as it were, the patient experience from being referred to a movement disorder specialist to actually getting DBS? How would it kind of impact? Is this just going to be 15 minutes in the scanner, or they're already having scans, right? So an extended scan, or is it going to be more intricate?
Lots of great ideas. So I think what we're trying to do here next, which is not the distant future, but sooner. So Mike Fox has just published one paper in Brain, just came out a few days ago with Martin Reich's first author, looking at networks that would impact cognitive decline based on deep brain simulation. And then we had a paper in Annals, I think, in a few years ago, which would look at depression as a side effect in Parkinson's disease. So which connections would lead to depression? So looking at then, now maybe looking at our database here locally and looking at which patients might have that symptom, and then re-inviting them to the center and trying to reprogram them. That would be one sooner avenue that we're trying to look into here. But I think long term, my vision would be to have symptom-specific network profiles, let's say one for tremor, one for bradykinesia, one for rigidity, but then also for depression and cognitive decline and all that mapped out in a normal brain as a library, right? So not patient-specific, but they are essentially maps that we can use. And then if a new patient comes in, we could check their symptom scores. Let's say they have a lot of tremor. We would then weight the tremor network more strongly to plan their surgery and then also to program them. And let's say we don't want any patient, of course, to get depressed after surgery, but maybe for patients that already have that type of problems before, that's an even higher thing we want to avoid even more than in others that maybe are really so we could wait for each patient profiles we have and find their optimal mix or blend of networks. We call that network blending, and then I think based on that, do surgery but also DBS programming. And I think that will be the future. I really think so. There will be a lot of other things in the future as well, like adaptive DBS and so on, but I think this will certainly evolve to be ripe for clinical practice at some point. And then I think an intermediate step that we haven't talked about now would be, we have the libraries and we have what the patient has in terms of symptoms. We want to scan also their brain and their networks and match their networks to the library networks, right? We want to see, we know the library network, but we want to see that in the patient in individualized form. So we would scan them before surgery. We would, they would get a resting state fMRI and a DTI scan, best we can do in a single patient. And then we would segregate their brain into the networks we know would respond to tremor, bradykinesia, and so on. Then do the network blending in their own brain and, of course, have it all individualized. I think that will be likely my program for the next, 5 to 10 years to develop that further, and then at some point also go into, clinical trials with that, hopefully. But
and would you see this being a tool that's kind of delivered through, with the kind of the DBS providers kind of a thing, or
long term, yes. Yeah. At the moment, it's research, right? Of course, but I think I would really see value in that becoming commercialized as well. And but first, of course, we have to show it's robust, it works, and it's a long way. Probably 5 to 10 years is probably wrong. It's probably my whole career or whatever. But it's going to take a while to make that transition to a truly, connectivity-based DBS, connectivity-informed DBS.
Do you think it will be sort of what other? I mean, I think it's always interesting to consider kind of like how disappointing kind of genomic studies in this area have been, right? And maybe that's because genomics have nothing to tell us about people's subtypes of disease, or maybe it's because we don't know how to analyze the data. What do you think?
Yes, so I think the audio glitched a bit, but what I understood was that the omics, so the genomics, wouldn't be helpful, or so far.
Well, I was just if you look at the literature, you probably know it better than me, but I looked at it relatively extensively about a year ago, and the results generally seem fairly disappointing. A couple of weak associations with sort of this gene or that gene, but really kind of the idea of kind of because one would hope maybe following a similar logic to that you're following connectomics, there would be a rich seam of information that would allow us to subtype patients genomically, and it wouldn't be the whole story. We might have to include, but there would be. Whereas really what I found was a couple of weak associations with a few genes, much less impressive as a story than what is going on in connectomics. And I wonder, why is that? Is that because genomics really is not that relevant for DBS, or is that because we don't understand how to analyze the data?
Yeah, it's a great question. So I am totally on board that no patient is alike, especially also in their genomics and so on. So that each Parkinson's patient will have to some degree a different cause. So there's great work by Alberto Espay that I interviewed for my podcast as well, and Ben Stecher, who's a patient but also patient advocate, that's really knowledgeable about these things. So they claim there's if you have 20,000 Parkinson's patients, you'll have 20,000 diseases, right? So everybody's different and so on. And I am not an expert in that, and I wouldn't even disagree with that. I would still think, though, that there will be, especially with something as simple as DBS, be some sort of common end pathway for a lot of patients. Maybe not for all of them, but for maybe 90% at least. That would still, the same networks would be affected, likely because of different causes, or in some patients especially would one network would be affected more than the other and so on. But that's exactly what we want to do anyways. But then how much the genes play a role in that, I would say that in Parkinson's at least that hasn't been investigated as profoundly in the big cohorts we had, for a good reason, because there wasn't any evidence that some subtypes would not respond to DBS, right? I would say most that would respond to levodopa as well, and most do, right? Most, let's say, genomic variations of PD, they would also usually respond to DBS if it's placed well. So it's very different in dystonia, I think, where people have really thought about or looked at, some subtypes would just not respond too well to DBS, right? But in PD, that didn't seem the case so far in history. So I'm not saying it doesn't matter at all. I think it will certainly matter to some degree. The question is, how much variance will genomics explain? And then the other point is, if we wanted to include that as well as a certain additional thing into these types of analysis, you just also again need more, and you need bigger studies, more deeply phenotyped studies, so more expensive studies and so on. So I see practical problems there, but rather than
gotcha.
It should be worth it to look at. Yeah.
What other data types do you think will be relevant that are not being? I mean, it's amazing the kind of I'm just trying to remember where it came from, but it was a study based on a questionnaire that was sent to several hundred DBS centers all around the world, and basically they were looking at the pre-surgical workup and what procedures are being done and what's not being done, and even the DOPA challenge is only being done at about 90% of places, but that's far and away the most common one. The next thing is 30% of places or 40% of places are doing a formal cognitive screen, and then it just goes down and down and down, right? The psychiatric screen a bit less, and so it seems like there's enormous heterogeneity, and there's reasonably good evidence that any of these things are somewhat informative, but no apparent kind of consensus about how we should actually work up a patient.
Great point. I still think the answer is somewhat close to what I just said, that it works so well in most patients, right? So there usually, if things work well, there's not as much incentive to change them, or to even sometimes to better understand them, because it, of course we want to understand it, but if it works, never change a winning system. Still, that being said, I think there's some cool work for other biomarkers pre-op, by the Minds group and also others, but looking at atrophy patterns. So, I think they could show that if you have a lot of atrophy in the SMA, in the supplementary motor area, then patients would not respond as well to DBS on average. And the reason could be that that's where the hyperdirect pathway originates that goes into the SDN. And maybe if, the disease has progressed already as far as that there's a lot of atrophy. It's just not, we can't revert the network changes as easily with DBS, right? So if I were to include additional things into such an analysis, I would probably use atrophy patterns as well. And that would essentially just be MRIs, right? So we would use, again, the structural MRIs for that. But and then I think, levodopa response, there is some doubt. Yeah, it is certainly a good predictor, or people think it's a good predictor. That's the consensus. There are some papers that showed, that, it might even sometimes be a statistical artifact. So, I don't even know how informative it is personally, but definitely word on the street says it is very informative. And I think there's been one paper from Grenoble where they looked at like really long-term outcomes just out in recently. I think they also came to the conclusion that at least for long-term outcomes, the levodopa challenge wouldn't even be that predictive, but there were different metrics, and I can't tell you which ones out of the top of my head, but they analyzed this in I think so far the longest period, so sometimes going up to 18 years or so.
I see. So very interesting. So finally, I just want to push up on one other thing, which is I think is also very interesting, which is that in your paper there was a very interesting discussion of particular networks being associated with particular conditions, such as PD or essential tremor, and then there being multiple possible sites that you can address, and they may have slightly different symptom profiles, but basically you could treat a disease in principle, I guess, by addressing any part of that network, because it would have a global effect, as it were, on the rest of the network. And then one of the things you pointed out was that, well, for many sites, you could access the network either transcranially with a non-invasive approach like transcranial magnetic stimulation, or invasively with an invasive approach like deep brain stimulation. So do you see the future of neuromodulation more generally sort of ultimately emerging from intracranial work to essentially being sort of programming nervous systems from outside?
Yeah, great point. So that is something my mentor Mike Fox has explored way more than myself. So he has a great 2014 PNAS paper out of that where he really looked at TMS sites versus DBS sites in different conditions. I think even 20 conditions or so, or around that number, and could show that resting state networks would always, in each single one, case, connect the two sides, right? So what we modulated up here would always, in all of these cases, be connected to the site that we would modulate in the subcortex with DBS. So that just made clear, or at least suggested quite strongly, that we seem to be modulating resting state networks, so brain networks, and we can do so from outside or inside. So I think it's a very powerful approach. I think practically speaking, one downside or one difference between something like TMS or TDCS, so the outside methods with the brain stimulation, is that the effect sizes are usually smaller in most conditions, at least, and then it's always also sometimes not long lasting, right? So that's so far unresolved. there's great work now also from our group, so from Mike Fox's group here with depression, TMS size, but also Nolan Williams has founded a company and has a good trial where they have found ways to, with TMS, have, much less stimulation time points needed for the same effects with, novel paradigms. And they could also use the fMRI networks to inform where exactly they would need to modulate. So they've really tried, I think, had great results in the depression field. So I do think, we should do that more for Parkinson's as well. Look at, which sites we could modulate. There has been some work in the non-invasive fashion as well, sometimes even with good results, but usually just not long lasting, right? So bradykinesia would come back after, I don't know, 30 seconds again, right? So you would see some effect, but it wouldn't last. So
yeah, there's some interesting work on the horizon. I think there's a trial that we're involved in with called the STEM PD trial that is looking at caloric vestibular stimulation.
Great, yeah, with the Cyan company. That's very interesting as well. Yeah, that's really not understood as far as I know, right? So far, but it's really promising.
Well, like the whole field, right?
Well, people always say we don't know how DBS works, but I would think that's not true. We do.
Really?
I mean, we at least know, a lot of things about DBS. We know it essentially stops information flow, right? And it has to be pathological information. So it will, all the literature on the beta power signal, there's a lot we understand. It's not that we, just put electrodes in the head and it works. And I would say even back in the day, the lesion surgeons that did it in the 50s or so, even they had really good theories of why they lesioned exactly the pallidum and so on. Right. So it's not that we don't understand how it works, right? And with the cochlear stimulation, so far at least, I've talked to the company as well, that so far it's great results, but I think their model currently is that it would modulate the whole brain somehow, right? So it's a wide connection of the vestibular nucleus, and that is, it could be that's the whole, all it takes to modulate, everything essentially. But I think there's no DBS level of understanding, right? So and that being said, I still think there's a lot to learn in the DBS field as well. So it's not that we understand it, but it's not that we don't know how it works at all, right? I would say. So,
yeah, but you'd agree that we're a long way away from being able to build a sort of in silico simulation of a patient and predict how they'll respond. But I guess your work is contributing to that process. There's some very.
It boils down to we don't understand how the brain works, right? That's the main issue here. Yeah. And I think with that you could say we don't know how anything in the brain, like MS or whatever you name it. We wouldn't know. We also don't know how Parkinson works. We could say dopaminergic neurons degenerate, but why does that generate Parkinson? So I think we have a similar level of understanding of how DBS works as how Parkinson's works, right? So I would say so, and it's not a mechanistic detailed one, but we have some clue. So
there still remain fundamental mysteries, right, about how neuronal communication and computation takes place. So absolutely not that surprising at all. Andreas, it's been a pleasure and very interesting, and I really enjoyed your review paper with Michael Fox. So thanks from me and to everyone else, because it's a great contribution, and I'll look forward to following your work in the future with interest. Yeah. Maybe we'll be able to talk again in a year or two and see where we are in terms of progress.
Great, thanks so much. Right.
Cheers.
Take care, John.